So good evening everybody. I think that was a very exhaustive and very elaborative talk by Professor Sareen. Good evening everybody and welcome back to this particular topic. I was told there may be some overlap with the slides, but I think there were too much overlap with the previous two speakers. We are talking about liver at the heart of the matter. NAFLD in type 2 diabetes treatment. What are the therapeutic choices that we have as on today 2018 in this IDEC Pune, the second international one. There is no conflict of interest over here. But we will take you through this particular agenda slide which will tell us what is NAFLD, what is NASS, that's a simple steatosis versus the fatty liver and the NASH. Why do we need to treat that? We saw it's been so rampant, whether it was obese or whether it was lean NASH. It's very important because of two reasons. Because both the non-hepatic outcomes of CVD and of diabetes are absolutely related to Indian population and the Southeast Asian population over here. Lifestyle modification would stand really importantly, and we will see how to differentiate between choosing grams versus losing grams, that the diet versus exercise. Although Nitin has shown some slides, but we'll still take up in details. What agents do we have? Oral versus injectable, surgical, or is there anything which can work in both the ways? What are these glitazones, the gliflozins, the gliptins, the vitamins, the exenatides or the liraglutides and the future trials? And let me tell you, there are immense number of drugs which are absolutely underway for these particular trials. And I would like to end towards about with the research that is there any other hormone beyond insulin which could help us in the treatment and give us a therapeutic choice with NAFLD. Irrespective of whoever, whatever says, NAFLD is in simple words is ectopic fat accumulation combined with a chronic inflammatory status, absolutely with the presence of insulin resistance, and it's the insulin resistance absolutely present over there. Why is it important to treat? I agree with Professor Sareen, it is a multi-system disease. Earlier it was thought to be a consequence, but now we know it's mutual as well as bidirectional. The most common cause of death is cardiovascular disease. And I think we should extend hands not only with hepatologists but also with the cardiologists and other team members, because it's going to be a multi-systemic approach seen more in males rather than females because of protective hormones of estrogen, independent risk factors of future metabolic syndrome as well as CVD. 20% of all of these NASH are lean in Asia, and they are different in Asia versus the Western. And another important thing is that the cost of treatment, once the patient has NASH, it increases by 26%, and by 2020, liver transplantation, the most common reason is going to be NASH and NAFLD. That's the multisystemic disease, how everything else would be involved. Some slides have also already been shown, so we would try to skip on them, but let me tell you, there was something called as a Sprint India in 2012, which was not diabetes and hypertension, but it was about NASH Sprint India, where it said about 57% of the population does have this particular prevalence in type 2 diabetes in our own population. So the question, 5% of this particular fat, which if it is present or if it is more than that, if we reduce, would it help in the management? And the answer is, let us look in the next slide that whenever there is a positive calorie balance, there is increase in liver fat, the cycle of the liver starts over there. Professor Roy Taylor has shown, I think I did hear you telling about that. That is where plasma glucose would increase by increasing the plasma basal insulin secretion, increase in VLDL, increase in islet fat, and that is where both of these start a spinning twinning cycle, and that is why we need to reduce the content of the fat, and which would be helpful, which would reduce the insulin, which would reduce the resistance, and which would reduce absolutely the plasma glucose, and hence decreasing the fat would also normalize the overnight blood glucose, which would be increasing, and also it would decrease and normalize the fat and in the insulin response to eating. And I agree with sir absolutely that it is a liver disorder. Whoever also apart from having liver lives more is going to get diabetes as well as NASH or NASH leading to diabetes. Therapeutic diet, few slides were shown in the earlier part, but it's important to know that a weight loss of at least 3 to 5% of body weight would reduce the simple steatosis, but if you want some changes more at the level of inflammation and other microarchitectural issues, you must lose by 7 to 10%. There can be a debate and a question about which diet to follow, but let me tell you here two things. Mediterranean as well as paleo both have shown to be reducing this particular liver fat by ultimately, it's the weight loss which is caused by whatever thing, and I agree with that slide of Nitin which he showed that it is low carb versus low fat, both can cause it. At any cost, please avoid fructose and not get carried over by those WhatsApp videos about eating a lot of fructose. Fructose needs to be avoided to avoid such complications of NASH and NAFLD, and it's the calorie deficit given by various bodies across the world that would actually cut down on the weight, and that is what would be the therapeutic diet for NAFLD and type 2 diabetes. Therapeutic exercise. I think both the earlier speakers did show about this particular thing about walking and exercises, but let me tell you, there have been papers in the last 6 months which says about the minimum dose of exercise of NAFLD. And I think we really want to know what's that minimum dose of exercise, or what's that minimum exercise. It says, the paper says, just being active. Don't just sit like a potato or a couch potato. Don't just be like a log of wood over the chair. Even for us doctors, we just need to be more active than what we were. So standing daily after every half an hour or so at your place itself could just be preventing your liver fat getting deposited into it. Both aerobic versus resistance can be done. Weight loss, even before you've lost weight, your exercise would actually reduce your insulin resistance and give importance and reduction to your NASH and NAFLD issues. But remember, if you're giving 150 minutes a walk per week to anybody or beyond that, it should tailor down to your patient's clinical comorbidity and capacity of fitness to exercise in that way. This is very interesting because Nitin said that if somebody has got no NAFLD, which is non-alcoholic, if you take alcohol in small amounts, he said, it may be helpful, but it's a question mark, he said at the end. But look, talking about therapeutic, I'm telling a straightforward thing, whether you drink alcohol or no, which actually you should not, but you can't smoke, because even that one cigarette a day may cause increased prevalence of NAFLD, as you see in this particular slide over there. So even if you're non-alcoholic, you need to be still non-smoker to avoid NAFLD with your particular disease. As I was talking about family history of diabetes, there is also family history of hypertension, smoking, HCC, that's the hepatocellular carcinoma, and others. Evidence of OADs. Let's come back to about, we agree that it's a disease, we agree. Now, how, when we join hands, we need to have something in hand to offer a patient. Nitin showed some 5 different types of patients. What are we going to talk to our patient? That the patient has come with a USG report, come with a diabetes report, come with a family history of NASH, family history of an HCC. How are we going to treat these particular patients? Some slides will be skipped. I think Professor Sareen did mention about metformin. Although it is there, there are a lot of benefits, but it is not first-line recommendation for NASH, but it is a first-line recommendation for type 2 diabetes, and hence, in that way, this should be the first line of treatment to give protection for, because of a lot of mechanisms that it can be done. Now, apart from metformin, there have been a lot of other drugs, but let me bring you back to the study called as PREVENT, where non-diabetic patients were treated with around 30 to 45 milligram of pioglitazone for around 16 weeks, and they had very good results with that. But let me draw your attention to, in this particular world and era of time, we do not want any amount of a cancer which could be caused by a tablet with such a high dose which was recommended by those particular studies, wherein most of them said about 30 or 45 milligram, and also we do not want a little amount of even weight gain, but here was at least up to around more than 10% of the weight gain, which we would not want in any of the diabetic patient. Hence, this is a questionable thing whether we would be using this drug in that much amount of dose to get it down. But let me tell you, the expansion of this particular molecules of PPAR, whether it was alpha, gamma or delta, this we have seen. INT131 is into research, into clinical studies. This is also into research, seladelpar. But saroglitazar is our own Indian molecule, which is at the moment approved for type 2 diabetes and dyslipidemia. And let me inform you and update you that there have been studies about saroglitazar and NASH which have been taken up in India and Mexico with various doses of 1 milligram, 2 milligram and 4 milligram. And I think by the end of 2019 or the start of 2020, we should have some results of this particular drug. Pemafibrate has been shown to be better in some studies and may be available, but we also should know that there is something called as a pan-PPAR agonist, and that is the IVA 337, which is doing really well, and that's the one in the center which has got all the properties of alpha, beta and gamma PPAR. What about the simple drug of diabetes after metformin that we would think of? We would think of a gliptin, we would think of an SGLT2, and if those two things do not, and if the patient is poor, we think about maybe glitazone or a glenide or something else, or maybe an injectable a little later. Vildagliptin reduces the fasting lipolysis and increases glucose utilization. Reducing fasting lipolysis would also reduce the hepatic acid input, which is very well documented a few years back, absolutely. Not only this, this particular elevations of ALTs and reduction after giving vildagliptin 50 milligram BD was sustained by around at least 6 months in this particular randomized double-blind placebo-controlled trial, and this is one of the gliptin which is shown to be beneficial. Not only it did reduce the plasma ALT, but also the fasting liver triglycerides, and the correlations were absolutely significant as shown in this particular slide. Coming to other drugs like either we talk about GLP-1RA, there have been numerous studies called as LEAN study with liraglutide, which came in JCEM last year, and the Japanese component, the LEAN-J. Both of them have shown that the reduction of fat was more than 10 to 20% of the total content that was there, with just a milder or a middle dose of 1.2 of liraglutide 1.2 mg per day. Also similar results were seen with exenatide 5 microgram twice a day. In combination, of course, there was a pioglitazone in that particular study, but exenatide, dulaglutide, liraglutide, all three of them have shown promises. And let me update you with one more drug, that's the semaglutide, which also has shown to reduce liver fat content. Studies are underway, but semaglutide is going to take over all these other three ones, all the three, lira, exena and dula, for three reasons. One, it is shown to be cardioprotective better than others. Two, it has got better control of glucose as well as weight compared to the previous three ones. And the third one, the oral molecule of semaglutide would really do wonders. That's going to be a one single pill, which most of our patients would expect. And as doctors, we would also want to give a drug which is to be taken orally rather than taken parenterally. Now, apart from this, after liraglutide and exenatide, we had a new class of drugs which came past 3.5 years, and that were the SGLT2 inhibitors. And let me tell you, there have been few studies which said about liver function test in type 2 diabetes, where all the three, ALT, AST and GGT versus either placebo or compared to another gliptin, sitagliptin in this particular study, showed benefit from LFT lowering as such, and for both in NASH as well as NAFLD. Effects of canagliflozin in NAFLD complicated was really nice. It was absolutely around 24-week treatment, and they highlighted the therapeutic potential, and there have been more recruitment of patients for this particular study as a therapeutic option for NAFLD complicated with T2DM. I want to really reiterate over there, there are two more points. One, that from India there has been one more study, Nitin will agree with me, and Professor Makkar is over here. We just had presented one study about empagliflozin and NASH and fatty liver reduction in ACE, and which was a very well appreciated paper. And the second thing, that after the role of SGLT2 inhibitors, which said that they can do really well in the heart failure and cardiac complications, now from endocrinologist, the SGLT2 has gone to cardiologist, and sir, day is not far when it will be the hepatologist with combined hands with us will also be writing SGLT2 inhibitors, barring their own contraindication and those other drugs. So implications for therapy have been there many. We can really discuss it for a long, but I don't want to wait in between you all and the very nicely set up gala dinner over there. In 2017, also we had this particular landmark paper I think, which talked about the pharmacological treatment of NASH and control of risk factors. I think my first slide talking about multisystem disease and Sir's last slide talking about multisystem disease, this is what in toto needs to be taken care from blood glucose control to blood pressure to lipid lowering therapy, and that is where we have to choose very wisely and smartly to get NAFLD down in patients with type 2 diabetes. This slide summarizes whatever we just discussed earlier, but orlistat, it does have effect on ALT and steatosis, but not a recommended drug. Surgery for more than 50 kg per meter square for non-Indians, and for Indians the margins are much less, but it has to be really an important complication and it has to be progressive. Let me tell you one more thing about the American Association Society for the Study for Liver Disease Guidance, which came again in 2017 when initially it came after 2012. It does say about that there have been a premature specific treatment for NASH and omega-3 fatty acids to be given when there is a concomitant hypertriglyceridemia. Pentoxifylline is not mentioned, and it was not mentioned even earlier, although it may be available and may be used in populations like Japan. However, pioglitazone, they still say in 17 that discuss the benefit risk ratio of vitamin E and this both, and to be used in biopsy proven if it's over there. Now, when we know about this, just look at this long list of histological improvement in NASH. To reduce these things, talk about incident neoplasms, not just HCC, but also the extrahepatic cancer, mortality and morbidity, symptoms of quality of life, patients related outcome need to be really important, QOL, labor productivity and well-being, and most importantly the economics. But for every treatment, as in diabetes, we have the ABC. There is an ABC for NAFLD also in type 2, and here A is not A1C first, but the ALT, which should be less than 30% from the baseline or less than 40 if you want to come back to your normal lifespan. But if you want to live for 100 years, then you please bring it to less than 20, as Professor Sareen said. Body weight, reduce at least 5 to 7% and reduce HbA1c as tightly as possible without causing hypoglycemia and others. Mention of two studies I was talking about. What is beyond insulin in NAFLD and T2? Can we take the use of two? These are two preliminary studies. I'm not advocating the use. In euthyroid subjects, thyroxine was given to 20 patients. This study which came in JCM in 2018 early, and they kept their TSH levels less than 1.7, and they found that there was a reduction in hepatic fat content. That is where the benefit of thyroid hormone analog also comes, that needs to be looked into. The second hormone which is beyond insulin and thyroid is the growth hormone. There is a somatotropin axis dysfunction which is there, and there may be a benefit in NASH. This again is a questionable thing, because in acromegaly we see actually a development of NASH. It's like saying PCOS primary versus secondary. It's like saying glucose being more in diabetes and more also in Cushing syndrome, but you have to remove that particular source. We have to wait for mechanisms and for other things that need to be done. There is a long list of drugs, and it would have been no end to that list. But this is a snapshot of about how new drugs are there with us. Cost effectiveness need to be taken absolutely for an important thing. I think this slide summarizes everything. I would call both my speakers to come for a question answer session. Over to you, Chair. Thank you so much, ladies and gentlemen.
Thank you, Dr. Shaikh. Now, may I kindly request Professor Sareen, Dr. Kapoor and Dr. Shaikh to take on the questions from the audience, please.
My point of view is the origin of diabetes is we are talking of type 2, is obesity. So it's an independent adipose tissue. The inflammatory markers, yesterday evening also I was talking about the origin of the inflammatory markers. Inflammation is a fat tissue. So the primary is the fat which is getting diseased. We are increasing the obesity, there is a lateral inflammation in the fat tissue. That's what is triggering for the development of the diabetes. Liver is coming secondary because of the development of the resistance. So my point of view is still the adipose tissue, which is the origin of type 2 diabetes. That's where. The second thing is about
can I first answer this part, because this is crucial. You have a pregnancy, gestational diabetes. I didn't have time to discuss. what happens in that, the liver gets fat, all the fat is accumulated. In fact, the liver fat content from 5% goes to 15 to 30% or so. The moment there is fat content, there is insulin resistance. You have gestational diabetes. The lady loses weight and it comes back. The second example is hepatitis C, which uses LDL receptor. So when somebody gets hepatitis C, liver gets steatotic and the diabetes becomes 3.7 times more. You treat hepatitis C, the receptor gets down, fat disappears, diabetes disappears. There are two clear examples.
Yeah, no, that's the thing. Ultimately, it is an increase in the adipose tissue mass, which is the first step which takes place.
No, intrahepatic. Intrahepatic. It is the diacylglycerol.
Before that, the standard adipose tissue has to increase, and later on, if there is an ectopic fat collection in the liver. So, liver comes second. If you want to confirm this, you have to do a HOMA. You have to do a HOMA IR at the stage when the obesity is developing, or a stage when the hyperinsulinemia has just started. And if you do a HOMA and you find an HOMA IR positive in hepatic insulin resistance, then we can say yes, the primary cause of the diabetes will be hepatic insulin resistance and not obesity.
Sir, I think
HOMA IR at the stage of developing obesity.
I agree with what you're saying.
Doing HOMA at a level of converting NASH into cirrhosis. I'm already doing that HOMA IR studies.
That's nice. That's a nice study. We would be really appreciating if you really come and discuss those results with us. I agree with your point, but I think even in lean individuals, without having subcutaneous tissue, if there is intrahepatic increase in content, then it can lead to insulin resistance and it can cause the origin of diabetes over there, and that is what I think was shown in those CT scan slides also, of comparing a healthy individual of BMI 22, and it was all the three layers. I think he had difficulty in showing the green one, but very elegantly that slide was shown. So I think the point is well taken, but it is possible even in lean individual without obesity, the way we see even thin type 2 diabetes. And we should not forget that Indians have a leaner adipophenotype, a leaner phenotype which can cause into this. Your next question, sir, please.
Building upon this, this can still go further. And yesterday only, I think the evening we are talking about receptor endocrinology. At that time it was estrogen receptor and it was part of HRT. Now it is insulin receptor. We have IR1, we have IR2, we have IR3 present on adipose tissue, liver and skeletal muscles, and probably on endothelial tissues also. If we can do an investigation and find out which one is initially getting defective, that will take the call whether the source is adipose tissue, liver or this thing. HOMA IR is one of those tests.
Let me explain. So the current data from the proton density magnetic resonance, which is now the global standard for measuring intrahepatic and intramuscular adipose tissue. All NIH trials are based on that. If your hepatic fat content is from 5% to 6%, 1% increase, you get insulin resistance. If it is 8%, it directly correlates with cardiac event. It is not with muscle. Intramuscular adipose tissue, if it increases from 5% to 8%, 3% increase, it correlates with insulin resistance. So there is a difference of 1%. There are two types of receptors, adiponectin receptor R1 and R2. It is R2 which is in the liver and R1. So lean people have adiposity. Their adipose tissue is defective. But obese and others generally have hepatic triglyceride, hepatic diacylglycerol, not triglyceride. Triglyceride is beneficial for liver. It is diacyl which causes. It is C8 to C10 which causes. These are all new facts. But just let me put it simply. We feel it is the intrahepatic resistance, and HOMA may not be the correct method. HOMA is very defective. It is just the pure insulin. If your insulin levels are going up, hyperinsulinemia, it is enough.
Professor Neglur has a question.
Wonderful presentations.
Thank you.
Second question to you. The CAP score that we have, continuous attenuation parameter score,
yes,
for the hepatic fat content, how sensitive it is
yeah,
in compared with the proton density Is it very close?
It is very crude. It is extremely crude, I must say, because it tells you the controlled attenuation parameter is based upon the amount of fat, which is 33% or less, 33 to 66% and above 66. But let it put, if it is less than 250, you are safe. If it is above 290, it is bad. But it does not give you quantitative.
We have plenty of scores, like the FIB4 score. How efficient all these scores to identify? Because the diagnosis of NASH and the NAFLD is difficult because most of the sonography report will say there is a fat contained liver. Now, most of us underplay it because we don't pay attention, because almost every diabetic patient has this kind of a report. To further confirm whether the patient definitely has the NAFLD, we need to either do elastography or we do CAP scoring or liver biopsy. Liver biopsy being invasive, most of the patients will turn down the offer and they will not do it. In that situation, whether we can use these scores, like FIB4 scores, how sensitive they are.
I'll tell you what I do. If a patient comes with fatty liver and his ALT is above 20, between 20 and 40, I will start worrying. ALT is less than 20, fatty liver, no worries. But if he has fat and ALT between 20 and 40, you should be careful, because ALT may be normal in half the people. So ALT is not a marker, totally clear marker. But today, fatty liver biopsy should only be done if it is stage 2 fibrosis, that is, the LSM, liver stiffness, is more than 8, then a biopsy. If it is above 14, no biopsy. Between 8 and 14, biopsy is required.
And question for Altamash.
Yes, sir.
You showed many drugs, and you did also show obitocholine.
Also showed?
Obitocholine drug, which is
Obitocolic acid.
Yes.
A Flint study, which looked at this molecule, which is an anti-fibrotic molecule.
Yes.
It's not still approved by US.
Not approved.
It's in final stage of
Most of these are not.
But the interesting part of this molecule is increases the lipid levels. So how safe it is and how likely it is to be approved?
So that is why we.
You want me to answer this?
Anti-fibrotic.
So that is why I think we should really wait till all these trials are done. We should wait when biopsy proven things are there, and we should join hands in management with hepatologists. So part of the answer will be by sir.
Yes, 1 minute on this. So I did not show you the bile acid pathway. Now what happens is the obitocolic acid is an FXR agonist. The moment it stimulates FXR, bile acids will go down. So it is a new method of measuring, but this part is not bile acid dependent. It is TGR5 pathway, which is based on muscle. So what happens is you decrease FGF19. The bile acid has to be reabsorbed in the enterohepatic circulation from the enterohepatic circulation. So the ABT, the receptor in the ileum, has to be down-regulated. FGF19 goes up, which causes the whole process. So today the cholesterol metabolism, the sugar metabolism, the thermogenesis in the muscle is TGR5 dependent. And that is where bile acids play. So any patient with NASH, bile acids are like this. You give obitocolic acid, bile acids come down, your thermoregulation, your sugar, your cholesterol get better.
And FGF21 is also implicated in the studies. So there are data coming of FGF21 also. 21.
So just a quick comment. The last speaker mentioned the possibility that SGLT2 may be beneficial for patients with fatty liver disease. The group from University of Florida, Ken Kusi, presented at the Endocrine Society. I chaired that session. And they presented randomized control trials with the use of SGLT2 CANA in patients with fatty liver disease before and 6 months after therapy. It was associated with weight loss, some decrease in transaminases, but the liver did not change. So SGLT2 in that study did not change the concentration of fat in the liver, but they didn't do biopsies. They just did MRI spectroscopy and an ultrasound. So it was not good.
So data is still upcoming, and I think we would wait for more data to come on that. As I said, there was a small study from India which was presented last month. which was on EMPA. One study I showed was on CANA. And as we move ahead, so for example, we had 4 years back, we had studies only of Xena. Now we had Lira studies also, which was lean and lean J. So I think time would tell, and maybe a subset of Declare, which is going to come next year, would also tell us. We really do not know. But maybe it may also be effective because of its mere weight loss. We need to really wait for those more data.
Sorry, can I respond to that thing with...
Yes, yes.
Canagliflozin and liver fat, we were part of those. It was a two-site study. We did it in San Diego and in Gainesville, Florida. It's complicated. It's not, it's the numbers game we play with the P less than 0.05. That was the main thing. But the method which we use to estimate liver fat, which as you know, even a liver biopsy is not the gold standard because it depends on where you're going to sample it. Whereas as of now, most people believe the MRS, proton-derived fat fraction, is probably the best way. The problem we had in that study was placebo improved a lot. We do not believe that placebo really can show so many changes. And there were 2 people who went completely the other way. So the people in the CANA group, we do not know if they took the drug or not. And the people in placebo lost a lot of weight, much more than even the SGLT2. So there were problems with it, but it's not a straight yes-no answer on that. I just wanted to mention that. Sorry.
Sir, Dr. Sareen, quick question for you. You mentioned that the HOMA score may be totally faulty and we should be looking at this pure serum insulin level. So, do we have any cutoffs for Indian population where we see if it is going up and whether it is the fasting or the prandial, and does it correlate with the glucose level also?
So, about 15 years ago, we were working on adiponectin. Indians, you know that in patients with obesity, the adiponectin levels are low. But in Indians who are lean, adiponectin levels are normal to high. And that's where we started working on adiponectin gene and its sequencing and its different variations. To our utter surprise, the genes are same, but adiponectin levels were extremely high or high in these patients. So we said, why is it? So Indians, about 63% of lean NASH are non-insulin resistant. I'm not talking of obese, I'm not talking of those. Lean NASH, 63% are not insulin resistant. So how do you find out? You don't have insulin clamp studies. You can't do any of these. So therefore, if you have a person who has normal sugar, but has very high insulin, but not above the limit of normal, and his IR is between 1 and 1.5, we will consider it. For others, IR of 2 is necessary. HOMA of 2 is necessary if he is obese, even 3. But for lean NASH, consider 1 to 1.5 as highly sensitive.
Thanks.
Sir, would you encourage or discourage the use of pioglitazone just on the basis of weight gain? Because the weight gain is mostly due to the fluid retention rather than fat, and it mobilizes the fat.
Right. So the dose was 45 milligram if you are talking about the NAFLD NASH part. Now, are we going to use that for Indian patient is questionable. So that moves out. Second, in populations where it is used, even though it is fluid retention, it is the weight on the scale which is increased, which means that much amount of extra drugs would be given in other issues.
Encourage or discourage the use of pioglitazone?
If you are able to use 45 milligram in a population not predisposed to CA bladder or other contraindications and does not have class 3, 4 heart failure and for a long time, because it was given for at least 2 to 4 years, that duration of time, in them only. But I think for our continent, we are going to use a small dose as we are going to, as we have seen in the past few years about its ups and downs.
Regarding the dosages of metformin in NASH, is there some guidelines for that?
Yeah.
Other was the articles which were there, the high dose metformin causing cirrhosis, and the cutout point was something like 3.5 grams. Now, what the possible such sort of mechanisms that what insulin sensitizers we use in lower dose may be helping in controlling sugars, but in higher dose, if you're trying to bring about insulin sensitization, is causing cirrhosis in the liver. So, Dr. Sarin will probably put in some FGF related thing which may help us out in this, or?
I'm very happy you asked. First, I want to ask how many diabetologists are using metformin in cirrhosis?
Nobody.
Child's A, A and B. So there are only 2 out of maybe 100 people. And child C? No. Child's B? Yes. So let me tell you how this whole work started. So I had a fellow who was working in Barcelona. He was working on the mouse model, and we found that metformin down regulates the HSC, hepatic stellate cell receptors. The stellate cells from active becomes quiescent. And in the animal model of CCL4, the portal pressures came down. This came into JCI about 3-4 years ago. We started with a DM student. Now he is a very popular hepatologist in Ahmedabad. It was his DM thesis, and we started with patients with NASH and cirrhosis, or patients with cirrhosis with insulin resistance. And I was telling someone close by that we have, before coming here, yesterday I checked up at ILBS, we have about 2,800 cirrhosis and diabetes. I didn't realize, now we'll work on it. Anyway, so metformin down-regulates and deactivates stellate cells. It brings down portal pressure. And it is a beautiful drug. I have now 2 to 3 year follow-up for these patients who have regression of varices. It is safe. It doesn't cause lactic acidosis unless it is child C or patient has bled. So today we have hundreds of patients who are cirrhotics, childs A and B, who are on metformin, who have lost weight because of metformin, whose diabetes is well controlled, portal pressures are controlled, liver fat. And we have a repeat biopsy, not only one. And this paper has been just submitted today for a review journal. So I think it is a very safe drug. Yes, sorry, it is up to 2 grams. We have used, no, not above 2 grams. We have used up to 2 grams, 1 gram twice a day in patient, and with sitagliptin very often.
Professor Mukherjee. We discussed, I did show in the slide. We showed.
This is undergoing trial in patients. There are 2 new drugs which are undergoing, 3 new drugs actually. One, the second generation obeticholic acids, next generation is now by Novartis, which is undergoing trial, Topo. The second drug is saraglitazone, and the third is ASK1 inhibitor, which is the apoptosis signal kinase 1 inhibitor, which has just recently been shown about a month ago to decrease fibrosis significantly.
Professor Mukherjee.
Follow on with the metformin, child A and B.
Yes.
Do you have data to say that in child B, when you're using metformin, it's beneficial to the, for the clinical markers?
It was presented 2 years ago. It's not published, so I can't say that we have data. It was presented. Till it is published, don't believe me.
Sir, I've looked at the literature for this. I'm searching it.
There is no data. There is just no data.
But you would still recommend A and B?
I strongly recommend because I use it. But I don't say that you use it.
I think his line was very interesting. Do not believe me. He said, do not believe me till I have published it. He said that at the end.
No. I told you the mechanism of NASH is twofold. It is cell death. Cell death releases DAMPs. DAMPs become PAMPs, pattern recognition receptors. It is not pathogen receptor, pattern recognition receptors. So a hepatocyte dies, it releases microvesicles, extracellular vesicles. These are picked up as DAMPs. They are picked up by 3 types of cells: Kupffer cells, immune cells, and stellate cells. The Kupffer cells will digest, put it back into the hepatocyte, so this cycle goes on. The moment you stop this death by decreasing fat, and metformin works on it, many drugs work on it.
Dr.
So
Neeta, please.
I think they want us to close down.
Yeah.
We can
I'm
discuss
extremely
it.
sorry for stopping such a wonderful session. Thank you all so much. Audience, please stay on. We have a wonderful, we can cut it down to 20-25 minutes where you will have the faculty on stage, and it's a completely open forum. If you can just line up behind the microphones, you can ask any question related to diabetes, endocrine, and the faculty will be very happy to answer, and it will be a very nice interactive session. Please stay on. We will start immediately.